We are privileged to be joined by Dr. David Hanley, Emeritus Professor in the Department of Medicine, who continues to make substantial contributions at the University of Calgary. After obtaining his MD from the University of Toronto, Dr. Hanley has focused his research on the hormonal regulation of calcium metabolism and osteoporosis. He also founded the Calgary Health Region's Osteoporosis and Metabolic Bone Disease Center, which is now named in his honor. Please join me in welcoming Dr. Hanley as he shares his in-depth research and insights into the cellular process of bone remodeling and the pursuit of bone-building therapies. Dr. Hanley.
Thanks very much, Lisa, and thank you to the McCaig Institute and to the Wood family for this wonderful forum. And now for something completely different. I do have disclosures. I've been wined and dined by drug companies in the past. So this has been discussed already, but the fact that our skeleton is an amazing architectural achievement because it's also able to renew itself and repair itself. And that occurs through the process of bone remodeling that's been mentioned already. This just shows the pattern of remodeling in two different kinds of bone. This is in trabecular bone, and this is in cortical bone. That's the tough outer shell of bone. And this is surrounded by bone marrow. So from blood vessels and from bone marrow, the bone cells get signals to either be quiet and do nothing, or else to start remodeling the bone that's there. So at some stage, the bone gets a signal, and in come cells called osteoclasts, which break down bone. And through other signals from the osteocytes, these little blue things here, and from osteoblasts, the lining cells, and later the cells that are building bone, the osteoclast gets signals to stop. Other cells come in to sort of lay down a cement line for the new bone, and then the osteoblasts come in and lay down new bone, and they get signals from the osteocytes when to stop. And this is the same process in cortical bone, the outer shell. And as mentioned, bone remodeling has a variety of actions. And this slide just really illustrates some of the cells and how they communicate with each other through the whole process. And this is a packet of bone that is remodeling. And the whole concept was introduced by an orthopedic surgeon working at Henry Ford Hospital, looking at biopsies of bone. And he came across and showed that the process starts with resorption or breaking down of old bone, and then the laying down of new bone. And that process and all of those cells and the layer and the area of bone that's made is called a basic multicellular unit or a basic remodeling unit of bone. And the skeleton's renewing itself at about 5% per year. And you can look at the skeleton as being made up of about 30 to 35 million of these little packets of bone. So as we slide down the razor blade of life after and you've seen a model of this slide before. So men do not go through menopause, and that makes a big difference. So this is what's happening to all of us, unfortunately, a slow loss of bone mass. And you've heard some of the methods we can use to slow this down. but there isn't really very much we can do about menopause and the bone loss that starts a little bit before the last menstrual period and carries on with a very high rate of bone turnover for about 4 to 5 years. Now, obviously, replacing estrogen at this time will limit that, and unfortunately, I don't have time to talk about estrogen replacement therapy here. But this, when we develop osteoporosis, it's one of these two mechanisms that's probably happening. Either the basic multicellular unit doesn't build back quite as much as it took away, or there may actually be a failure of this reversal process and the laying down of new bone. In each case, there's bone loss. In this case, there's a lot of bone loss. And in this case, and we don't know which is going on in each individual person, but this is the case probably for making a major bone building process. Most of our drugs that we use for osteoporosis reduce the rate of bone turnover and maybe reduce the rate of resorption, and that may bring this into balance. For this kind of problem, you need something to stimulate new bone formation, and we've all been trying to search for a drug that would do that. And so our frontline therapies, as I mentioned, are all anti-resorption agents, basically. And estrogen is a very good one, but carries with it some baggage. The main drug that we use would be bisphosphonates. Some of you may have run across alendronate or Fosamax. That's probably the most popular one. And recently, because of our understanding of how osteoclasts are recruited, a blocker of the major chemical messenger that starts the process of osteoclast recruitment and maturation is an effective therapy as well. But the idea is that with anti-resorptive agents, you get a maintenance of what we've got, or maybe a slight increase. If we had a formation stimulating agent, we might see a steady rise in bone density. And fluoride was brought forward as the candidate of a bone builder in the 1970s and maybe a little earlier. So fluoride has long been known to stimulate osteoblast activity. And when people get way too much fluoride, as is fortunately very rarely occurring, but scientists noted that this was associated with very excessive bone apposition. And one of my mentors, Joan Harrison at the University of Toronto, she was a medical physicist and used nutrient activation analysis to show that in fluoride-treated patients in clinical trials that were going on at Toronto, she showed increased skeletal calcium. And early small clinical trials showed promise. So in the mid-1980s, the National Institutes of Health in the United States sponsored 2 randomized placebo-controlled trials of a high dose of sodium fluoride at 2 centers in the United States, Mayo Clinic and Henry Ford. And this is what they saw with the bone density. It was amazing over 4 years, a huge increase in bone mass. But then they looked at fractures, and there were actually more fractures in the fluoride group. Now the problem with fluoride is the dose. And this was probably slightly too high a dose. And the big problem is, how do you find the right dose? And the problem with fluoride is it's just too hard to do that. These 2 studies effectively killed the use of fluoride as a treatment for osteoporosis. And around the same time, people were looking at parathyroid hormone. And parathyroid hormone is the hormone that pulls calcium out of your bones and maintains your blood calcium. So that might not be a good idea, except we know it stimulates bone turnover. And in fact, very early after parathyroid hormone was isolated, Hans Selye and Bert Kollop at McGill University documented that if they gave injections of PTH in rats, they actually saw more bone. And Chirk Tam at the University of Toronto, working with Tim Murray, Chirk found a nice method of making human parathyroid hormone and used it in some studies and showed that if you gave the parathyroid hormone as a continuous infusion, you didn't really get much. You got a lot of bone resorption going on. But a daily injection increased bone formation much more than increasing resorption. And this was repeated in 1997 by another group in the United States. And again, intermittent exposure increased osteoblasts and bone formation. Small clinical trials were showing increased bone histology and bone density. And then in 2001, a large randomized control trial showed marked improvement in bone density with 18 months on average therapy and significant reduction in fractures. And this is what bone looks like after fluoride or after parathyroid hormone. You can see these are iliac crest bone biopsies, and you can see the marked increase in bone. So we now have 2 drugs that act and are approved for osteoporosis treatment. Sorry, I'm hitting the wrong slide here. Teriparatide, which is a fragment of PTH that contains all the biological activity, and a growth factor called parathyroid hormone related peptide can actually do the same thing with a lesser increase in raising blood calcium. These 2 drugs now have been approved in the United States and teriparatide in Canada. It's a daily injection of 20 micrograms and initially approved for 18 months, now good for 2 years. Abaloparatide is, I hope, waiting for approval in Canada. It's a much larger dose because of less calcium activity, and it may even have a greater bone response. I'll just leave this up here for a moment for you to copy down the amino acid sequence of the 2 agents. The other advance that has occurred with again, the examination of coupling and the bone remodeling unit and the chemical signals that keep it moving is another anabolic therapy, which is an antibody to sclerostin. And this was discovered through examination of families with an unusual bone disease called sclerostosis and major overgrowth of bone. And this is how much the skull from a person with one of these disorders weighs compared to normal human skulls, just as an illustration. But the problem with this disease is that there's so much bone that in the skull, it actually starts to cramp off the optic nerve and cause hearing loss. So it's not a good thing to have, but what was discovered by studying these people and a family of people with very high bone density who were perfectly healthy was a new pathway of activating the osteoclast, and with it was a substance called sclerostin, which will inhibit that pathway. Now the osteoclast, or the osteocyte rather, and the osteoblast are the main stimulator, and the osteocyte in particular stimulates the whole process of bone remodeling. And it puts it in balance by stimulating bone formation, but also stimulating the shutting off of bone formation by with this substance it makes called sclerostin. What has been developed by Amgen is a substance called romosozumab, a human monoclonal antibody to sclerostin. So it prevents the activation of the Wnt pathway in bone formation. And huge clinical trials have been done with this agent and you can see marked increase in bone density and a reduction in fractures with this agent, which is now in use in Canada. It's a monthly subcutaneous injection of 210 milligrams. It's 2 injections actually at the same time. Now, in one of the clinical trials of this drug, a trial that was comparing romosozumab to alendronate, one of our standard therapies, there were more serious cardiovascular events in that trial. In the major clinical trial, there was no increased cardiovascular event. But because of the second trial, its approval in Canada and the United States has a caution not to be used in patients who are at high risk for cardiovascular disease. That's remained a controversial point here, actually. But at present, that is the way it's currently made available. A recent systematic review of all the osteoporosis drug therapies that we have available found the anabolic agents that I've talked about here are superior to the other therapies in fracture risk reduction, but all of the therapies are better than a placebo. And at present, most of the osteoporosis guidelines recommend the anti-resorptive therapy first, and the anabolics are saved for people who are at extremely high risk for fracture. And after you treat with these anabolic therapies, what happens? Well, as I've pointed out, you've only got a limited amount of time you can take them. And the bone gains are slowly lost over the first 1 to 3 years, and so is the fracture protection. So if you're on one of these drugs for bone benefit, you really have to follow it with another drug to maintain those gains. And I'll just show you some of the costs here. And I think the costs are very unfortunate, and that's the reason they're not really widely used. The teriparatide is now generic. The original brand name was Forteo was well over $1,000 a month. And in fact, in the United States, it could have been as high as $3,500 a month in some pharmacies. Romosozumab is $800 monthly. And neither of these are covered by Alberta Blue Cross, but they are covered by private insurance plans. Teriparatide can be obtained through Alberta Blue Cross through the Special Authorization Program in special cases. But this is what happens when we give, this is one of our patients who participated in one of our trials. We followed up the parathyroid hormone with alendronate, and she went from an osteoporotic T-score to a normal bone density and maintained it normal for her age. So this is what Osteoporosis Canada's new guidelines come up with. So not everybody needs drug therapy, of course, but But bisphosphonates, alendronate, risedronate, or zoledronic acid are the are the first choice. For people with really severe vertebral fracture problems or two vertebral fractures and very low bone density, anabolic therapy would be recommended. So I'll close there and left with my usual problem. We have far more questions than answers here, and I look forward to developing more newer therapies and safer therapies in future. And right now, I think we still have too much of this and not enough of this. Thank you.
Thank you, Dr. Hanley. Okay.